All right, we'll get started. This is the panel discussion on symptomatic management for the rare neuroimmunologic disorders. I will introduce myself because I don't think I've done that to the full group. My name is Paula Hardeman. I am one of the PAs in the neuroimmunology clinic here at UT Southwestern. I have the, I guess I'll use the word privilege since he's in here working very close. Okay, now that he's gone, no, I'm just kidding. I have the honor of working with Dr. Greenberg along with the others on this panel. And so I'll let them introduce themselves. And then we want to keep this very informal. It's just an open question. But if people are going to be quiet, which I doubt with this group, we will just start the conversation. So, Crystal.
I don't know if these mics are.
They're on.
Oh. My name is Crystal Wright. I'm a nurse practitioner in the neuroimmunology clinic.
Hi, I'm Lindsay Horton. I'm one of the neuroimmunology faculty.
I'm Rajashree Srinivasan. I'm a pediatric physiatrist and I work with Dr. Greenberg in the demyelinating disorders clinic.
Okay, so we'll turn it over. Is there any general questions or don't all speak at once?
This is
symptomatic management. So as we've probably heard from the earlier discussions, the different symptoms that can be associated with any of these conditions is a wide gamut. So, oh, okay, we got a question. I was going to start my little...
So I'll start it off. We have a child with TM and she had it at a very, very young age. So under the age of 1. I hear an awful lot and I read an awful lot about neuropathic pain and pain problems, but she has not exhibited that or at least has not told us of that. Is that something that we can expect as she ages? Is this something that because she didn't have it initially that she maybe won't have it as she ages? Because we've seen a lot of things, she's kind of grown into some disabilities. So I was just curious what your guys' experience has been.
Roger, you can start.
Okay. I don't think I have seen anything to indicate that, but I guess I wouldn't say that it could never happen.
Yeah, I would agree. I mean, I think it would be unlikely at this point if she hasn't experienced it. I mean, I primarily see adults. It seems that pain is more common in adult patients, but I think it would be pretty unlikely.
I would say most of the time the pain is present after the acute attack right away. And sometimes the pain can change over time, but it usually doesn't appear years later in my experience.
And if I could just add a point to that.
Yeah.
And also I think that she doesn't know anything different. So it's hard for her to even determine what could be pain. That could also be one of the factors.
That's a good point. Okay, I think we have another question.
What are your primary tools that you use in managing the pain associated with these disorders?
There's lots of tools. Dr. Horton.
Sure. So pain is probably one of the most common symptoms we see. So neuropathic pain in patients with transverse myelitis or neuromyelitis optica, these similar conditions. And it can be really challenging sometimes. And so I think we all kind of have different approaches and it can be very individual and patient based, depending on the type of pain, how severe it is, the medications they've tried. But in general, we use a lot of different medications like gabapentin, pregabalin, duloxetine, things like that. And usually just kind of maximize the doses and, see what works for each individual patient.
If those traditional drug approaches do not work, what other approaches have you tried?
So it's tough. Some patients find things like acupuncture beneficial. There are other kind of approaches. I don't know if Crystal, do you have any other thoughts outside of the traditional approaches?
So I also think that sometimes it's a different type of pain. So it's important to kind of ask those questions to determine, is it a neuropathic pain Or is it a muscle type pain that they're having? And that's why the medicines that we would use for neuropathic pain, the anti-seizure meds, aren't working. Because maybe it's more of an ache. Maybe there's poor body mechanics or things causing the muscles to hurt, and they're interpreting that pain as their TM pain. And it's more of muscle related. So sometimes we need to approach it from the muscle standpoint with muscle relaxers or Botox or the baclofen pumps, things like that. And sometimes that can help the pain. We also have patients who try more natural approaches. Some of the amino acids have a little data to help with pain. And then there's, of course, the popular topic of THC or CBD for pain, that sometimes individuals will go that route as well.
Are there any new investigations ongoing for trying to address the pain without impairing cognitive function, which all the things you've mentioned do? They impair cognitive function and can increase fatigue. So it's a pretty bitter pill for a patient to swallow. Is there anything else in the horizon that gives any hope for managing the pain without compromising neurologic function?
I think that's why we try sometimes the antidepressant medications to manage pain, things like duloxetine or venlafaxine, because they don't tend to cause as many cognitive issues or the fatigue that we see with the anti-seizure medications or even the spasticity medications. And the amino acids, of course, don't cause fatigue. So there are limited options that don't have those side effects. The other thing we find is sometimes if we go very slowly with the titration, their bodies adjust to it and they don't have as much fatigue or those types of side effects if they slowly kind of increase. But it is very limited, and there is not any magic pill out there that gives you the benefit with maybe no side effects or no potential side effects, unfortunately.
I will add, as just a alternative to the medications that some of my patients have found useful with neuropathic pain or pain in general, is massage therapy, or really making sure, because sometimes, to Crystal's point, which she was pointing out, it's not necessarily that it's truly nerve pain, but there's just increased tone or tightness within the muscle. And so I always explain it to patients that you keep in mind that you've got nerves going to that muscle as well. So if you've got a tight muscle pressing down onto a nerve, you could be getting this mixed picture. And so sometimes it helps to really focus on, can we get the muscles to relax? And that can also ease pain. So massage therapy has been something a lot of my patients have found very useful. If you have a health savings spending account or something, you can use your money from that to pay for a massage if you get your healthcare provider to write a prescription or a letter of medical necessity. Chip the mic right there.
Oh, I'm sorry. I was just going to mention that right now we're working with the Dr. Conda about pain pump. In fact, Gary's going to go and have the pain pump test done in another couple of weeks.
Good, good.
So they're hoping that might help. He's
the-
got the same situation. Nothing has worked.
Yeah. And so just so you know, what the pain pump allows is to give very smaller doses of some of the medications like the gabapentin, different things that can cause a lot of that cognitive deficits that you were, explaining. There's a way to get that small amount right to the area where we need it, and then a patient can have less of those systemic side effects. She'll continue to say.
Yes, I'm glad that you mentioned massage therapy. I was just gonna ask what your thoughts are, or if you do recommend your what you call this adjustments,
Mhm.
your chiropractic adjustments, if that's recommended for us, because I don't know about everybody else, but I get neck pains,
Right.
and massage does help. And I did get an adjustments a few back, but I wasn't really sure if it's something that I should get familiar with. So I'd like to know if that's recommended and if it's something that I should like get familiar with.
In general, I do not advise chiropractic adjustments. Massage therapy is fine, but the manipulations they do can injure blood vessels in your neck, and that can increase risk of stroke. So generally, we do not recommend that.
I've also had TM patients who have had a kind of a flare up of their symptoms from the adjustments. So I also do not recommend adjustments.
Sorry.
Yeah, go ahead.
To tag on to the earlier question about fatigue and things like that. My question is, do you guys ever use any neurostimulants or anything in the adult population to help with that aspect of cognitive fog or things like that?
Yeah, so these are fatigue in general. I mean, we see this with all these autoimmune neurological diseases. And so, I mean, in general, we do often try things like amantadine, modafinil, other stimulants if the fatigue is very debilitating.
Okay, Paula, one of the things you told me a while back is a TENS unit,
Yes.
and because that interrupts that pain. And I have used that off and on through the years, and that has been very beneficial. And then the rehab and getting a good rehab, if you have a good spine person, they'll help you with a massage and stretching, and you can do that at home. Most of the time, no, not everybody can, but that seems to be more help for me.
Yeah,
Keep
that's
moving.
a great suggestion. Working with on the rehabs side of things, I'm very blessed in where I work that I have a lot of good rehab colleagues that I can ask questions and come up with some different regimens for my patients, as getting them with a TENS unit or learning how to do the different type of stretches, or sending them to the physical therapist so they can really teach them how to do those appropriate type of stretches as well.
And I also think aqua therapy, like water therapy, can really be helpful for pain. I'm not sure if it's just the exercises itself or the water pressing on the extremities and helping circulation move around. I don't know, but many patients really benefit from water, swimming, water aerobics, or anything in the water tends to, yeah. And then they can exercise without having pain associated with it too. Like water therapy?
Yeah, like hot water and like hot water, like getting into a hot tub and getting into like a.
So with any of these neuro conditions where you might have damage to the central nervous system, we don't actually recommend getting into hot water because it can affect how your body is sending signals through those pathways. And can bring on symptoms. And so cool water is what's recommended. So no spas that are hot tubs, things like that. I think I looked up the other day, the temperature needs to be around 84 degrees, nothing in the 90s for comfort.
And also no, what is it called? Is it like ice cold tub as well? That's not recommended as well. Ice cold tub.
Like the
I think
ice
I've read something
baths.
about that as
I
well.
don't know that we ever recommend it for patients, but I do have some patients that like really cold water. They do ice baths, but I haven't seen any data on using it for.
I don't
For
think it's really been
neuropathic.
studied, but
Yeah.
if you could tolerate it.
Yeah,
If
that would
you
be
can
similar
talk-
to like cryotherapy, where it's like the cold therapy. I do have some patients that say it does help them, but there has not been any studies. They're just, they find something that helps them.
Yeah, because I think I read something about like doing like switching between the two, like doing a really hot tub and then switching into like a cold one and like switching between the two, and apparently it helps. I don't know.
Can I clarify that? Are you talking about for that area of the body or the whole body being immersed in the hot water?
Yes, the whole body
the
being
whole body.
immersed into them.
I don't know of any data about that.
In rehab, we'll recommend contrast baths where if you have like, for instance, an injured arm or anything like that, that you dip it in hot water and then in the cold water. So you're alternating it, basically trying to get the nerves going.
Mhm.
So, but the whole body, like Dr. Horton said, there's no data out there about that.
Okay.
I think I have a question right here in the
So I
front.
have kind of two questions. One, she has a 50-degree, over 50-degree curve scoliosis. So she does see a chiropractor, but he does not use physical manipulations on her. Yeah, I don't know what it is. It's a thing he holds in his hand and he puts it and it clicks, but he never like pops her neck around or
Mhm.
anything like that. So what do you feel about that?
That would be fine. And the massage, a lot of chiropractors have massage therapists in the office and they use massage therapy as part of their plan. And all of that is fine. It's the
Okay.
manipulation that I try to get patients to avoid.
Okay. And then another thing for her, because we're very new into all of this, so she doesn't understand her pain, a lot of it. So she calls it skin sensitivity. So it might be on her right thumb one day, her left arm another day. It might hurt when she touches something cold. It might hurt when she doesn't touch it at all. It's very hard to determine. She might wake up one day and both her knees hurt so bad she can't walk. She gets a weird pain around her ear, jaw, neck area. It's hard to determine what is what and how do we know. So I contact the doctor about everything. He's probably sick of me by now, but I mean, is there a way to determine what is what? I mean,
So there was a talk earlier on, is it a relapse or is it a?
Mhm.
Yeah.
So what I tell patients is a good rule of thumb is it something you've had before? Because if it's something you've had before, most likely you're having trouble conducting signals through that pathway. And if that's the case, we don't necessarily need to hear about it, but let's try to manage the symptoms like that. You don't need to go to the ER for that.
right.
But if it's a brand new symptom that you've never had before, and it's in an area where you haven't had those types of symptoms, it is a good idea to go ahead and notify your provider because it could be that it is a new inflammatory relapse. But if it is an older symptom or something that has been intermittent in the past, so if she's had that same sensation on her thumb 5 or 6 times in the past, even if she hasn't had it for 6 months, that's, there's more, you want to think, did she get hot? Does she have an infection? Does she have, a
Right.
UTI or something like that that might be contributing to these old symptoms kind of coming back? But if it is a brand new thing that she's never complained of before, that's where I would definitely call the
Well,
provider.
the needs definitely were, and the doctor at home, he didn't really know what to do about it. Actually, it was his assistant, but we just gave her Tylenol and Motrin, and a couple hours later, she was able to walk again. But she hasn't had any more pain. But so sensitivity that moves from right side to left side, thumb to calf, whatever, that is all considered the same because it's skin sensitivity, even though it moves around.
It depends. Like if her symptoms have always been right-sided or left-sided, they may be just still on that plane, but in different areas. And then you can also look at the length of time that a symptom is present. If it's something that's inflammatory, it's not going away in 2 or 3 hours.
Okay.
It's going to stick around for a few days. So if you give a symptom 24 hours and it's still present, that's more of a sign that it might, if it's new and around for more than 24 hours, more likely to be inflammatory than just trouble working around damage that was previously present.
Okay. Thank you.
Any Denise, I think, oh, you don't, okay. You're just stretching. Okay. I got it.
So
Oh.
it seems like the go-to is gabapentin, okay?
Not necessarily.
For neuropathy, okay? So I have a doctor that doesn't really know what I have, and she's good. She spends a lot of time trying to figure it out. It seems to be like that's what everybody goes to now is gabapentin.
It's an oldie but goodie.
But I'm 6 years in, right? And I was on 2,700 a day, and then I started monitoring what I should do. Is there a length of time? Because I know cognitively, it absolutely affected me. And I went to my doctor and said, she's, yeah, okay, let's just cut back. But they don't know. Is there a length of time that's recommended to be on a certain amount and then try to reduce down? I mean, is there any, because it just seems like that's what everybody goes to. For my dog, they give, gabapentin. It's for everything because the opioid thing's done, right? So now it's gabapentin. Is there a certain amount of time that is recommended not to be on 2,700, based on what your pain is, I don't know if that's a question you can answer or not.
Yeah, I mean, I don't think there's a maximum amount of time. Like if it's working well for you, I think you can be on it for as long as it works well. But if you're on,
cognitive over, 7 or 8 years, you're on that long.
I would say at that point, it's not,
Something else.
if you're having side effects from it and it's affecting your day-to-day life, it's no longer the most appropriate drug for you. Does that make sense? Like, at that time, I would discuss other options. There are other things to try. I wish the list of things to try was longer, but if you're not getting benefit or your benefit is at a cost to you, then maybe that's not the most appropriate drug for you. And I think you should try to have that conversation to look at other options. Does that make sense? There's not just gabapentin. There's pregabalin, there's other anti-seizure medications that can be used off-label for pain. Yes, so gabapentin is a seizure medication. There's multiple other anti-seizure medications that can be used in place of gabapentin that you can try. It doesn't have a 100% success rate with everyone, but everyone's a little bit different. So we do trial and error to find the right one. And then there's also the antidepressant medications that may be an option there. And there are other things to try besides gabapentin. Gabapentin is used first because it's cheap and it is well known, and but there are other things if gabapentin is causing side effects. So I wouldn't put up with side effects just because. I would encourage you to try other things if you haven't exhausted those avenues.
I personally haven't, and I don't know that anyone else in our group has. But oftentimes we can offer referral to pain management specialists, and then, I don't know if they would consider that. In general, I haven't seen that that's the most effective for neuropathic type pain or spasticity type pain. But in theory, if several options have been exhausted, that's a conversation you could have with a pain specialist.
Any other questions? Truly good.
And mushrooms.
Oh, of course, somebody would ask the controversial question. So we're in the state of Texas, and neither one of those things are. I'm just kidding.
I've had a problem for 2 decades, and I've tried every drug I've heard mentioned here. I was taking 5 of them in 2016, Lyrica, Zymbalta. I don't remember. I had a hallucination. And the only thing that I found that helps me at all to sleep, and it doesn't help much anymore, are THC edibles. And I did move specifically from the state of Indiana to the state of New Mexico, not only for the weather, but because I knew that it would be available to me. And I've not found it to be particularly helpful, but I have read a lot of things about particularly the mushrooms helping with depression. And I'm just curious. It's probably too new and not a lot of people know.
So to your point, the mushrooms is fairly new, and they're doing something what they're called microdosing. So they're trying to come up with these very small amount to give to help with. And I feel like it's more of a very refractory depression that's failed other things, and a really bad anxiety. The THC, it's been looked at more for spasticity type pain, especially in MS patients. And if I remember correctly, it's kind of like a 50-50 from the data standpoint. Some people it works really well in, some people they don't get any benefit. The one thing I do caution my patients, if they're in an area where they're going to consider trying a THC, is there is some cognitive side effects that can come with it as well. So it's what Crystal was explaining, it's that risk benefit ratio. If you're okay with just a little bit of brain fog, but it really improves a lot of the pain, then that's only a decision you can make off of what's comfortable for you. Do you have anything to add?
Yeah, I would just agree with that. Like Paula said, the mushroom, that kind of stuff is new, so we don't have much to say in that regard. But for the THC, it's been mostly studied for pain related to spasticity and spasms, so not really like the neuropathic type burning, tingling pain. And a lot of it is, yeah, about 50-50. Some patients find it very beneficial, others don't, or can't tolerate the cognitive side effects or other type side effects.
So I've been told a lot that THC or like edibles are really helpful, and I've tried it a couple times and it has made me sleep better, and because I haven't been sleeping very well just because of everything going on. If you do it in moderation, will it affect you cognitively, or is it like if you abuse it? Because yeah, like long term, because my neurologist in Oklahoma told me that it would be fine for because I'm wanting to go into neurology. So I have to be sharp, But he said it would be fine as long as I'm not abusing it. But I just wanted like more opinions.
I do think the cognitive effects are dose dependent. And in the MS trials, it affected their cognitive functioning for up to 30 days after dosing. So I do think it is something that is likely to occur around the time that you take the dose, not months later. And so I do think it's kind of dose based and kind of an acute side effect.
So the cognitive effects aren't like a long-term thing
Correct.
that I would be dealing with when I'm like 30 going into
So
the
when,
medical
when
field.
when I send someone for neurocognitive testing, I ask if they're taking THC, and if they are, I ask that they stop it for about 30 days before the testing so that we can have more reliable results.
Okay, thank
Yeah.
you.
Any other questions? I know we're getting close to the break time and everything. We have one back here.
Have you found that the more pain that a patient is experiencing, the greater their fatigue? Because I mean, to me, just observing it, it's almost like the pain exhausts the patient. And that's why if you can't control the pain, you're never going to be able to control the fatigue.
Yeah, I mean, because pain can be so difficult to manage and can be such a kind of day-to-day problem, it can significantly affect patients' quality of life, whether that's fatigue, depression, or other kind of mood-related symptoms. And so definitely, if it's not well controlled, it can definitely cause other symptoms like you're mentioning.
Hurry, Denise, hurry.
Dr. Horton, I'll be seeing you Monday.
Hi.
Is the chronic fatigue and the horrible brain fog, is that a possibility of getting on disability with just that?
That'd be a question for you, Crystal.
So it's hard to get on disability with
Wait, I
just
think
the
you should
cognitive-
explain why that's a good question for you,
All right.
Crystal.
So I do the disability clinic within our neuroimmunology clinic. So I see patients who are planning on filing for disability, or they're having difficulty in the workforce, where I can help them with accommodations or things like that. So in my experience, if I have someone who comes in and it's a mobility issue, it's a little more straightforward when they file for disability. They're more likely to get approved the first time. But when it's a subjective symptom like fatigue and cognition, it's a little bit harder. And so for those patients, I would highly recommend doing neurocognitive testing so that we can measure it and put a number on the cognitive issues. And then I do give fatigue scores and things like that. And I try to make sure those things get put in the record to help them when they apply. But when you apply for disability now, it's no longer like your provider saying, oh, this person's disabled, they should get disability. It goes in front of a group of physicians that review your chart and look at it. And so they do put higher weight on objective data versus subjective. And unfortunately, those are subjective symptoms. Can they be disabling? Absolutely. Can they affect your performance at work? Or make it where you come home from work and all you want to do is lay on the couch and go to sleep? Yes. So it is possible to get disability for that, but it is a little harder. And it may take some time for approval, and your cognitive functioning would need to be at a level that is quite significant.
Well, if I were an employer, I wouldn't hire me.
We can talk about it on Monday, but if we haven't referred you for cognitive testing, we could.
She can refer you to come and meet with me.
Yeah, and that too.
Any other questions? Okay, so we'll go ahead and get prepared to wrap up. And what I would like to ask for each of the panel members, from a symptomatic standpoint, is there a certain education point or just a thing that you share with patients as they try to manage this very diverse disease, and that can have a whole bunch of different symptoms associated with it? Crystal, just because you're on the end and we're going to go.
Paula likes to pick on me.
And that's true too.
I would say the biggest thing is stress management and making sure that you're balancing your symptoms, your home life, all of those things together. And if you're constantly in a stress cycle, things are going to be worse. If you're managing stress, taking that time for yourself, making sure you're taking care of yourself, exercising, eating well, hydrating, then symptoms are going to be better. And so I think just managing stress and managing your body as a whole is probably more important than any of the medications we can give you, other than the prevention medications, of course.
And I think just to kind of add on to what Crystal said, not only just, stress management and taking care of yourself, but, a lot of these symptoms are invisible and they're not apparent to your loved ones, your friends, your family, your caregivers, things like that. And so having events like these where you can bring your family and kind of educate others on what you're experiencing, I think can be very valuable, just because looking at you, you may not appear disabled and people don't know what you're going through. And I think it just helps to have others kind of recognize how significant these symptoms are in your day-to-day life.
Rajashree?
I work mainly with kids. So from my perspective, when I see my patients in the clinic, I'm usually reviewing what education they have regarding their spinal cord status, about gallbladder management, spasticity management, and things like that. So, and of course, in kids, we cannot do anything without school being a part of the whole discussion. So that is also something that we talk about, making sure that the kids are attending the school, functioning at school adequately as well. So just overall, globally, looking at the whole picture.
Yeah, and I agree with everything that's been said. I'm a real big pusher in my visits of talking about stress management and just taking care of the whole self, and not just focusing on this neurologic condition. But I also want to make sure my patients have, if they have blood pressure issues, that they have good blood pressure management, because that can also have an effect on your nerves. So everybody's usually aware that diabetes can, but there's other conditions too. So I am a big pusher on making sure you're going in for your preventative screenings, you're having your yearly physicals, you're doing those other things just to take care of the whole self. So it's very easy to think, oh, my neurologist is the only person I need to see because of this complex neurologic condition. But please keep in mind, there is a role for your internist, your primary care, because there's just other things from a whole management that needs to be taken care and addressed as well. So I think we are to a break time. So we'll let everybody break for about the next 15. Dr. Jacobs is next, and he's going to talk about bladder management, which is always an exciting discussion. So we'll be starting back at 3:15.
So
All right, thank you.
Bladder now.
Thank you, everyone.